Good afternoon. It's my pleasure to thank the PSA for inviting me to share my expertise in regional anesthesia. My topic for today, regional anesthesia in cardiothoracic surgery, moving towards an opioid-free anesthesia. My objectives are to discuss the different fascial plane blocks for cardiothoracic surgery, also to discuss the paraaxial and neuroaxial blocks for cardiothoracic surgery, to enumerate the different studies supporting the benefits of these blocks, local and international, and recommendations on how to start these blocks in your practice. I have no conflict of interest to declare. Regional anesthesia is the use of local anesthetic agents to provide postoperative anesthesia instead of opioids. It is also used to reduce or avoid opioid use and move towards an opioid-free anesthesia, part of an opioid-sparing multimodal pain regimen during cardiac and thoracic surgery in order to promote early extubation, reduce post-operative complication, minimize the length of ICU and hospital stay, and reduce overall cost of perioperative care. Opioid-free anesthesia is a combination of various opioid-sparing strategies like regional blocks and non-opioid medication, culminating in complete elimination of opioid usage. Multimodal postoperative analgesia is a method of pain management which combines various groups of medications and local anesthetic for pain relief. Like in this picture, you can deposit local anesthetics into the skin through field blocks, through peripheral nerve blocks, and through epidural. The regional blocks that I will discuss for this cardiothoracic surgery are the fascial plane blocks, the paraaxial blocks, and the neuroaxial blocks. For the fascial plane blocks, gaining popularity for thoracotomy and sternotomy, presumed to have a better safety profile compared with the neuroaxial blocks, and it is easy to administer with the use of ultrasound. The described fascial planes contain nerves providing sensory innervations to the chest wall regions of interest, and deposition of local anesthetic within the fascial plane is expected to block the targeted nerves responsible for nociception related to surgical incision. The local anesthetic spread within the fascial plane is influenced by the volume injected, and high volume injections are expected to provide a better spread within the targeted plane. For the thoracic intercostal nerves from T1 to T11 are primarily responsible for the sensory innervation of the chest wall. Each spinal nerve exits an intervertebral foramen, then divide into a dorsal and ventral ramus, which communicates with the sympathetic tract by the white and gray communicantes. So in this picture, for the PEX1, the lateral pectoral nerve are blocked. For the serratus anterior block, the lateral intercostal cutaneous block of T2 to T9, and for the intercostal intercostal fascial plane block, the anterior intercostal cutaneous nerve are blocked. And for the erector spinae plane block, the dorsal rami supplies the muscle, the bones, the joints, and the skin at the mid-back, and the ventral rami run together with the blood vessel initially between the pleura and the endothoracic fascia, then between the internal and the innermost intercostal muscle, innervating the lateral and anterior chest wall. Depositing the local anesthesia to the transverse process blocks the dorsal ramus and the ventral ramus during erector spinae block. For the serratus anterior plane block, at the level of the mid-axillary line, the intercostal nerve branch pierces the internal and external intercostals and the serratus anterior muscles and give rise to the lateral cutaneous branches responsible for the sensory innervation of the lateral chest wall. The rest of the nerve courses anteriorly towards the sternum and pierces the internal intercostal muscle, the external intercostal membrane, and the pectoralis major, providing sensory innervation for the anterior chest wall. For the PEX1 block, this is popularized by Blanco in 20 2012, in which in 2011, I mean, it was administered to approximately 50 patients for breast cancer, and a minimal need for additional analgesia was observed. PEX1 block is performed in a supine position. A linear ultrasound probe is placed in the mid-clavicular line below the clavicle, and the probe is moved inferolaterally to the level of a third rib, showing the pectoralis major muscle, the pectoralis minor muscle, and the thoracoacromial artery. Again, this is a picture. If you do an in-plane approach for the PEX1 block, the local anesthesia is deposited in the clavipectoral fascia. In a study by Dr. Yoshima in 2017 using cadaver, he injected 10 mL of blue dye, and after 10 minutes, the spread of the blue dye was assessed. For the site of PEX1 injection, also affects the distribution of the block. The more lateral injection spreading towards the axilla, the blocking the intercostal brachial nerve, and the more medial the injection spreading towards the midline, blocking the anterior intercostal nerve. Then in 2012, Blanco reported the pectoralis 2 block that was designed for untreated pain over the serratus muscles area during breast expander and subpectoral prosthesis insertion. The PEX2 block blocks the long thoracic and the thoracodorsal nerves and the lateral cutaneous branches of the internal costal nerves from T2 to T9, providing innervation to the serratus anterior muscle and the lateral chest wall. The PEX2 block is performed in a supine position. A linear ultrasound probe was used, and it is placed in the mid-clavicular line below the clavicle. The probe is moved inferolaterally to the level of the third rib and a slight medial tilt. The three layers of muscle can be identified: the pectoralis major muscle, the pectoralis minor, and the serratus anterior muscle. A single site can be used to preserve the near-fielding imaging with the deposition of the local anesthetic first between the layers of the serratus anterior muscle and the pectoralis minor. Then the needle is withdrawn with the injection between the pectoralis minor and the pectoralis major muscle. The serratus anterior plane block provides analgesia to the lateral chest wall, blocking the lateral cutaneous branches of the intercostal nerve at T2 to T9. This was popularized again by Blanco in year 2013. My approach is I apply a linear probe placed on the T4 rib or region, then slide the probe downwards to the mid-axillary line, revealing the T4 rib, the serratus anterior muscle, and the latissimus dorsi muscle. Another patient. Then the local anesthetic is deposited in the serratus anterior plane, producing the serratus anterior plane block. And again, PEX1 block aims to block the medial and lateral pectoral nerves. PEX2 block aims to block the anterior division of the thoracic and intercostal nerve from T2 to T6. Also, the long thoracic nerve and the thoracodorsal nerve are blocked. The serratus anterior plane block targets the lateral cutaneous branches of the thoracic and dorsal nerve at T2 to T9. But there are two blocks: the superficial serratus anterior blocks. This block the local thoracic nerve and the thoracodorsal nerve because they lie on top of the serratus anterior muscle, aside from the T2 to T9 lateral cutaneous thoracic branches. But for the deep serratus anterior block, it is a better choice in selected cases where fibrosis and scarring of the superficial plane may prevent appropriate local anesthesia spread, or the superficial plane has been compromised by surgical manipulation. In a study by Dr. Kumar regarding the efficacy of bilateral pectoralis nerve block for ultra-fast tracking and postoperative pain management in cardiac surgery, 40 patients was enrolled in the study undergoing CABG or valve surgery, midline sternotomy under GA. divided into two groups. Group 1 did not receive the PEX, and the Group 2 bilateral PEX block. With the result, no? The PEX block pain scores at rest and cough were significantly low at 0, 3, 6, 12, and 18 hours from extubation. But after 24 hours, the pain score were comparable. Another study by Dr. Bashandi regarding pectoral nerves 1 and 2 block in multimodal analgesia for breast cancer surgery, a randomized clinical trial in which 160 adult patients was included in the study for elective unilateral modified radical mastectomy under GA. They are divided into two groups, the group 1, the GA alone, and the group 2, the GA plus PEX block. The result, the GA and the PEX block has statistically significant lower intraoperative fentanyl consumption. Also, it has a statistically significant lower BAS score in the first 12 hours and shorter PACU and hospital stay. Another study by Dr. Magun regarding a randomized controlled comparison of serratus anterior plane and pectoral and intercostal nerve block for post-thoracotomy analgesia in adult cardiac surgery. 100 adult patients was included in the study for elective cardiac surgery thoracotomy incision at 4th or 5th under GA, divided into three groups. Group 1, the post-op serratus anterior plane block. Group 2, post-op PEX2 block. And the group 3, post-op intercostal nerve block. The result, there is the early VAS scores at 2, 4, 6 hour post-extubation were comparable in the three groups, but the late VAS scores at 8, 10, 12 hours post-extubation is significantly lower in the serratus anterior plane block group. The PEX2 group demonstrated significant lower VAS scores versus the intercostal nerve block in the 10 hour, and the mean post-extubation VAS scores at 12 hours between serratus and the PEX2, it is significantly lower in the serratus anterior plane block. The length of stay in the ICU was significantly lower in the serratus anterior plane block and the PEX2 block versus the internal intercostal nerve block. For the pecto-intercostal fascial block, it is a parasternal infiltration of local anesthetic close to the branches of the intercostal nerves to provide analgesia after sternotomy. With the advent of ultrasound, the pecto-intercostal fascial block was introduced as an adjunct to the PEX block, providing analgesia to the anterior chest wall innervation. In this picture, the PEX major and the internal intercostal muscle and the transverse thoracic muscle in which the local anesthetic is deposited within the pectoralis major and the internal intercostal muscle around 10 to 20 ml is deposited. Okay, in a study by Dr. Kera regarding ultrasound-guided pecto-intercostal fascial block for post-operative pain management and cardiac surgery, a prospective randomized placebo-controlled trial in which 80 adult patients was included in the study requiring median sternotomy. It is divided into two groups, the group 1 receiving the PIFB and the group 2, the placebo group. The result, the group with the PIFB showed a statistically significant VAS scores, but the 48-hour cumulative OPD requirement is similar to both groups. Another study by Dr. Kumar regarding pecto-intercostal fascial block as a novel technique for post-operative pain management in patients undergoing cardiac surgery. 40 participants undergoing the cardiac surgery divided into two groups, Group 1 and Group 2. The Group 2, those received the bilateral pecto-intercostal fascial plane block after completion of surgery before shifting to ICU. The result, the post-operative pain was measured after extubation at 0, 3, 6, and 12 hours, and the pain in Group 2 was significantly less and lasted longer versus the Group 1. For the erector spinae block, the has been recently utilized for acute postoperative analgesia involving the chest, the thoracic, the cardiac, and abdominal surgeries. It is also referred as the paravertebral block by proxy, in which the local anesthetic is deposited at the erector spinae block. Local anesthetic is deposited at the costotransverse process, preventing nociception along both the ventral and dorsal rami of the spinal nerves. In this picture, for the erector spinae block, the trapezius muscle, the rhomboid muscle, and the erector spinae muscle, in which the needle is directed to the T5 process, piercing the erector spinae plane, in which the local anesthetic is deposited, blocking the dorsal rami and also the ventral rami. In a study by Dr. Macaire regarding ultrasound-guided continuous thoracic erector spinae block within an enhanced recovery program is associated with a decreased opioid consumption and improved patient postoperative rehabilitation after open cardiac surgery. A patient match controlled before and after study. 67 patients was included in the study. For group 1, no erector spinae plane block, and group 2 with continuous bilateral erector spinae block after J induction. Then after 8 hours of loading, a catheter is connected to a pump infusing intermittent automatic boluses of ropivacaine. The result, the morphine consumption was significantly decreased in the erector spinae plane block group in the first 48 hours. The intraoperative sulfentanyl was also decreased, and there is an early rapid patient mobilization and decreased VAS scores during chest tube removal. Another study by Dr. Krishna regarding the bilateral erector spinae plane block after acute post-surgical pain in adult cardiac surgical patient, a randomized control study in which 106 individuals are included, divided into 2 groups. The group 1 received the ultrasound-guided bilateral ESP block before anesthesia induction at T6 transverse process, and the group 2 only received the paracetamol and tramadol. Result, the median pain score at rest after extubation in the group ESP was 0 at 6 hours, 3 at 8 hours, and 4 after 10 to 12 hours post-extubation. And they also has a significant higher mean duration of analgesia as compared to group 2. For the thoracic paravertebral block, it is a paraaxial block which produces a unilateral somatic and sympathetic nerve blockade that is adequate for surgical anesthesia during breast surgery and for analgesia when pain is of unilateral origin from the chest or abdomen. The thoracic paravertebral space is a wedge-shaped potential space on either side of the vertebral column contained in the extrapleural cavity extending from T1 to T12. The anterior lateral border is formed by the parietal pleura, the posterior border, the superior costotransverse ligament, and the medial border by the vertebral body. I usually use a linear probe for my transverse approach for the thoracic paravertebral block, in which I place the linear probe midline to the thoracic spinous process, example here at T6, then revealing the spinous process, the costotransverse joint, and the lamina. And I slide the probe laterally, revealing the costotransverse process, the parietal pleura, the paravertebral space, and the lung. I direct the needle tip into the paravertebral space after piercing the lateral costotransverse process. There is a give and a downward displacement of the pleura is observed during local anesthetic injection. For the dosing, according to Dr. Chima, 1.5 milligram per kilogram of local anesthetic produces sensory loss at the level of injection with a mean superior spread of 1.4 dermatomes and a mean inferior spread of 2.8 dermatomes. But according to Dr. Karmakar, there are no published data comparing the distribution of anesthesia after a single site versus a multi-site percutaneous thoracic paravertebral injection. Current evidence suggests that a single site injection is as effective as a multiple site injection at 3 to 4 ml per site, producing a unilateral anesthesia over 4 to 5 thoracic dermatomes. This table is a recommended use of thoracic paravertebral block, according to Dr. Mark Karmakar. It could be used for postoperative analgesia, surgical anesthesia, acute post-arthritic neuralgia, chronic pain management, fractured ribs, therapeutic control of hyperhidrosis, and liver capsule pain after a blunt abdominal trauma. In a study by Dr. L. Shora regarding the bilateral paravertebral block versus thoracic epidural for post-control post-cardiac surgery, a randomized controlled trial, 145 patients was included in the study. For Group 1, had ultrasound-guided bilateral thoracic block, and for Group 2, thoracic epidural analgesia. And the result, there's no significant difference in BUS scores immediately after extubation and also after 12, 24, and 48 hours. But the Group 1, the ultrasound-guided bilateral thoracic paravertebral block, had significant shorter ICU stay and lower incidence of urinary retention and vomiting. Another local TMC study by Dr. Xiao, regarding the effects of ultrasound-guided multi-level thoracic paravertebral block versus general inhalation endotracheal anesthesia in video-assisted thoracoscopic surgery on clinical outcomes, a retrospective study. The objective of this study is to compare the preoperative outcome, including hemodynamic stability, oxygen saturation, pain scores in the first 48 hours, length of stay, incidence of adverse event, and postoperative nausea, vomiting, who underwent the BATS deloculation or decortication under ultrasound-guided multi-level thoracic paravertebral block versus JETA. The PVB group, the T3, T5, T7, or T4, T5, T6, and the GA group, the DLT versus the EC blocker group. Result, there was no statistical difference in the pain score at 24 to 48 hours post-op. The intraoperative and post-operative opioid use, the incidence of PONB, and the length of hospital stay between two groups. Again, the table showing the NRS at 24 to 48 hours, the opioid use, intraoperative and postoperative, and PONB, and the length of hospital stay. Another local study by Dr. Lasak regarding the patient outcome after undergoing multi-level thoracic paravertebral block, T4 and T6, erector spinae plane block at T2, and PEX1 block, a retrospective case series for 20 patients undergoing MRM or total mastectomy with or without ALND. The objective of this study is to determine the outcome after undergoing the combination multi-level paravertebral block at T4 to T6, erector spinae plane block, and PEX1 for modified radical mastectomy or total mastectomy with or without axillary lymph node dissections. The parameters to be measured are the pain scores using NRS, incidence of POND, the rescue analgesic, and the length of PACU and hospital stay. In Table 2, this shows the mean anesthetic induction time performed with the three nerves around 24.42 minutes, and the mean local anesthetic dose among the 20 patients are 2.34 milligram per kilogram, and the patient was sedated with propofol having a mean effect site of concentration of 2.64 microgram per ml. The 24-hour NRS rating scale was 1.55, ranging from a 0 to 3 pain score. The length of hospital stay averages around 59.6 hours, and the length of recovery room stay 50.5 minutes. Conclusion: the combination of the thoracic paravertebral block, the erector spinae plane block, and the PEX1 is an effective and safe alternative anesthetic technique for patients who will undergo mastectomy with minimal postoperative pain, and majority of this patient was discharged at home on the first postoperative day, but future study may explore the feasibility of total mastectomy or MRM as an outpatient procedure. For the thoracic epidural block, it is a neuroaxial block used to achieve a somatosensory and motor block between the T1 to T8 level while preserving diaphragmatic motion. According to Dr. Minervini, even this technique is widely used to provide effective pain relief. It is related with several complications like hematoma, nerve injuries, and hypotension. Precisely because of hypotension, the patient can require more fluid or vasopressor, slowing down the enhanced recovery program. For the thoracic epidural analgesia for cardiothoracic surgery, according to Dr. Vaidya, it is most commonly used modality for postoperative pain management in thoracotomy patient and was considered to be the gold standard. And according to Dr. Gasalino, that high thoracic epidural anesthesia T3 to T4 in cardiac surgery has a reversible sympatholytic effect and has the capability to attenuate the response to surgical stress and to improve both myocardial metabolism and perioperative analgesia. These beneficial effects have been proved to enable earlier extubation and a smoother postoperative course. But the missed disadvantage is the neuroaxial hematoma. And according to Dr. Stenset, epidural catheter insertion in a day before surgery for cardiac surgery has at least 16 hours prior to heparin administration was considered to be safe, and no case of epidural bleeding or neurologic complication was noted. But according to Dr. Horlacher, there are no documented spinal hematomas with neurologic dysfunction in their study. It is important to note that even in a large study, the finding of 0 events does not imply the risk is 0 in the whole population. And a table by Dr. Horlacher regarding the stratification risk for according to procedure in regional anesthesia in patients receiving antithrombolytic and thrombolytic therapy. The low risks are seen in the superficial and compressible plexus and peripheral nerve blocks, and high risks are seen in the neuroaxial blocks and the deep non-compressible plexus and peripheral nerve blocks. But still, the decision to perform spinal or epidural anesthesia should be made on an individual basis, weighing the risk of spinal hematoma with the benefits of regional anesthesia for a specific patient, especially for those receiving antithrombolytic and antithrombotic and thrombolytic therapy. For the non-cardiac surgery, in this patient, thoracic epidural was used in all of these patients. The unilateral MRM, the bilateral MRM, and the excision of mediastinal mass with midline sternotomy and hemiclampsial incision. The MRM, thoracic epidural, is inserted at T6 level with propofol via TCI used for sedation, and a volume of less than 15 ml of local anesthetic was used. For the excision of mediastinal mass with midline sternotomy and hemiclampsial incision, it is done under GA, and the thoracic epidural anesthesia was inserted at T6 level with the infusion of local anesthesia via PCA at 5 ml per hour. And my recommendation on how to start the nerve block for cardiothoracic surgery: talk to your surgeons regarding a plan. Start with the fascial plane block with sedation or after intubation. Always compute for your maximum dose, and if feasible, volume for fascial plane block should be at least 15 to 20 ml. For median sternotomy procedure, either do a bilateral PEX1 and PEX2, or bilateral PEX1 and serratus anterior plane block, or bilateral ESP. For MRM, total mastectomy, you can either do a PEX1 or PEX2, PEX1 or serratus anterior plane block, or ESP at T5, T4 level. For advanced block, using thoracic paravertebral block, do multi-level injection. Example for MRM, T2 to T4, T6 with a local anesthetic volume of 5 to 7 mL per injection and sedate the patient using propofol. For thoracic epidural anesthesia, insert at T6 level with a local anesthetic volume of around 10 to 15 mL. Always practice and study before doing the blocks. It's never too late to learn new tricks. These are my reference. And thank you for listening. If you have any question, you can email me. Thank you.